Today, we are diving into a medical mystery that's honestly pretty terrifying and sends millions of us to the emergency room every single year: chest pain. It's one of the biggest challenges in medicine because that one single symptom could mean so many different things. You know the feeling, right? That sudden, out-of-nowhere tightness or pressure. Your mind just starts racing. Is this heartburn? Did I pull a muscle at the gym? Or is this it? Your body is sending out an alarm, a signal, but what on earth is it trying to tell you? So let's think about this a different way. Don't think of it just as a symptom. Think of it as the very first clue in a high-stakes medical investigation. Your doctor becomes a detective, and we're going to follow right along with them, step by step, to see how they crack the case.
Okay, so first things first in any investigation. The detectives have to line up all the potential culprits. And believe me, the list of suspects for chest pain is surprisingly long.
I mean, look at this. The pain could be coming from your heart, sure, but it could also be your lungs, or your ribs and muscles. Or it could be something you ate, a gastrointestinal issue. It could even be a physical symptom of anxiety. This massive range of possibilities is exactly why you can't just guess. The investigation has to be methodical.
And the first rule of this investigation is to go after the most dangerous criminals first. Before anything else, doctors have to check for the life-threatening emergencies. We're talking about a heart attack, a pulmonary embolism, that's a clot in your lungs, or an aortic dissection, which is a tear in your body's main artery. You have to rule those out right away.
With those urgent threats front and center, the real detective work begins. And you know where the first piece of evidence comes from? It's not a fancy machine or a lab test. It comes directly from you. From your story.
This is what investigators are listening for. This is the classic textbook description. When a patient uses words like pressure, tightness, or squeezing, it points right towards what's called myocardial ischemia, which is just a way of saying there's a dangerous lack of blood flow to the heart. It's the #1 clue. But this case is often anything but classic.
And get this. This is where it gets wild. Up to 1/3, 1 out of every 3 patients having a major heart attack do not report any chest pain at all. That classic clue we just talked about, poof, it's completely gone in a huge number of cases. And those missing clues aren't just random. A major study called the Virgo study found huge differences between men and women, especially younger ones. Women were much more likely to have other symptoms, like pain in the jaw, neck, or arm. They were also almost twice as likely to think their symptoms were just stress or anxiety. And here's the kicker. They were more likely to be having a heart attack with no chest pain whatsoever.
And age changes the story too. For patients over 85 who are having a really severe type of heart attack, known as a STEMI, only 57% of them actually feel chest pain. That means for almost half of them, the main clue just isn't there. They might just feel super tired or short of breath instead. The type of pain is also a huge clue for other conditions. So for pericarditis, which is an inflammation of the sac around the heart, the pain is often sharp and it feels worse when you lie down. But compare that to an aortic dissection, that tear we mentioned. The pain there is famously described as a sudden, intense, tearing feeling that goes straight to your back. Every single detail of the story matters.
Okay, so after listening to the story, it's time to gather the hard evidence. The investigation moves from what the patient feels to the cold, hard, physical facts of the case. And this is the standard operating procedure. It starts with the history and a physical exam. Then you get an electrocardiogram, or ECG, to check the heart's electrical signals. And finally, a blood test to look for something called cardiac biomarkers. These are proteins that basically scream, heart damage. So the ECG is a huge piece of evidence. There's a specific pattern doctors look for called an SD segment elevation, and it's the single best predictor of a massive heart attack. But, and this is a huge but, up to 20% of people having a serious cardiac event have a completely normal ECG. So a clean test does not close the case. And that's where the blood test becomes the smoking gun. See, troponin is a protein that leaks out of heart muscle cells when they're damaged. The new high-sensitivity tests are so good, they can detect even microscopic amounts of it in your blood. It's definitive proof that the heart has been injured. It confirms the diagnosis. So now our detective has all the clues. They've got the story, the exam, the ECG results, and the blood work. The last step is to put it all together, crack the case, and figure out just how serious this is. Now, to make sure this isn't just about hunches or guesswork, doctors use these really clever scoring systems. They're tools that combine all the evidence in an objective way to calculate the odds of a major cardiac event. And one of the most common tools is called the heart score. It's a fantastic acronym that perfectly sums up the whole investigation. You get points based on your history. Is it suspicious? Your ECG? Is it abnormal? Your age? Your risk factors, like smoking or diabetes? And finally, your troponin level. And what it tells you is incredibly powerful. If you get a low heart score, your risk of having a major cardiac event in the next 30 days is less than 2%. That gives doctors the confidence to say, okay, it's not your heart. But a high score? Well, that confirms it's a high-risk situation that needs immediate action. But what happens when the whole cardiac investigation comes up empty? Your heart score is low, your troponin is normal, your ECG is clear, but the pain is still very real. So what's causing it? This might be the biggest plot twist of all. It turns out that after you rule out all the dangerous hard stuff, panic disorder is an incredibly common cause. It accounts for up to a quarter of all these ER visits for chest pain. It's a real diagnosis, but it's one you can only make after all the other dangerous suspects have been cleared.
So, we followed this whole investigation from start to finish. We've seen all the clues and how they fit together. What's the one thing you really need to take away from all this?
Here it is. The bottom line is that chest pain is never simple. It's always complex. We've seen how symptoms are not one size fits all. They change dramatically depending on your age and your sex. A complete step-by-step medical investigation is the only way to find the real culprit. And maybe most importantly, never brush off your symptoms as just stress or indigestion without getting checked out. So, we've decoded the signals, we've followed the clues, and now you understand the investigation. But knowing is only half the battle. The real question is, are you prepared to listen to your body and act on those signs? Any signal, no matter how small it seems, is worth paying attention to.